So what would it help to improve a culture in the NHS of information being used?
Thank you. So our table had 5 points, five things we thought we should be thinking about. So the first one was around capacity capability. So we started off by talking about the importance of information analysts and having career profiles, succession planning for those very important people that can actually do clever stuff with data. But we then broadened it out and said, actually, it's part of everybody's job to be able to do basic analysis and understand the importance of data and what the information is telling them. So the action was around to promote the culture. We need to start right back at medical school, clinical training, that actually this is part of the day job for everybody. So we need to get that, I think, instilled. And that's not a quick thing, but I think it's something culturally we have to drive through the system. The second thing was around performance management, the discipline point around, consequences against behaviours, picking up people on inappropriate cultures and behaviours, but also rewarding the good. So lots of actions around that. We talked a bit about league tables and the pros and cons of them, recognising we're always going to get those, but we just need to describe the limitations of those so we don't become over-reliant on them. We talked about ownership, the importance of ownership, particularly of clinicians owning their own data, but also I think patients. I think the key message today is getting patients much more involved in their own data so that it isn't something that happens behind closed doors. And then finally, I think there was something around levers and incentives, and particularly if we're going to change the cultures in boards and chief executives, we need to change the environment around them, and some of the tools we've got at the moment, and PBR is the classic example we talked around, which doesn't exactly drive great behaviours in terms of driving up quality of care. So we need to think around how do we change the levers in the system. Okay.
Did you identify any particular levers that might be worthy of further investigation?
Well, I think the payments ones are really one.
Yeah.
Payments goes to the heart of what we do, and how, if we're going to shift care from big expensive hospitals into better settings with better quality, we have to get payments to follow that. And I think there's a wide-scale recognition that actually, whilst we're starting to reward quality more, we need to think much more closely, I think, around our payments policy that will actually drive money and therefore different care systems.
Okay, very good. Table over here, have you got anything to add to? There's a huge list.
Yeah, without repeating what's already been said, we did discuss initially the incentivising from the commissioning perspective, particularly regarding remote care. Carrying on from the last point, we had an example where a clinician is delivering care remotely via email and providing an excellent service to patients, but his organisation is not recognised and not supported financially in delivering that care. Now, my chief executive cites the traditional banking industry where 20 years ago you'd have to make an appointment between 9 and 3:30 to go and see your bank manager, withdraw your own money out of the bank, where now you can access your banking 24/7 via your iPhone, etc. We believe we should be delivering healthcare and be incentivised to deliver healthcare in that way. We heard earlier on from Great Ormond Street regarding children and their iPads. We believe that technology should be readily available for patients to carry their own health record round, and we used an example of perhaps issuing patient records in a Kindle type app, where we've been delivering maternity care with patient records, carrying great big bundles, and mothers and future mothers of being the owner of those records. We should look at that kind of technology as well. But incentivising remote care was a key aspect of our discussions. Also acknowledging the good practice that is already taking place within the health service already. And in the main, we believe people want to do the right thing, therefore we should educate and encourage where their knowledge is lacking. The final point I'll make is we should be making the information public. We believe that the more public the information is, the more it will incentivise both our boards to pay attention to that information and take the appropriate actions to improve the care that is delivered.
Mm-hmm. I mean, your points about comparing the NHS to a bank, I think that was something that was echoed in Martin Elliott's paper as well. But I'm also mindful of the comment from the table over here. Not everybody is internet savvy, not everyone's got an iPhone. So does that suggest we've got to have different ways of making information to patients more accessible?
There was an absolute acknowledgement around the table that not everybody is internet savvy. I think we said 8 million people didn't have access to the internet. There are, most people have access to the telephone, so there are telephone services where they can discuss information. I work for NHS Direct, so of course we provide millions of patients with information. So there are other services without having to access a computer or the internet. But we did discuss other forms of providing patient information to them without it having to be through a computer. But particularly a strong aspect was around the Kindle and the patient being responsible for their own health record.
I like the idea.